So next case is toxic megacolon, and it's V44. A 28-year-old male presents with abdominal pain and bloody diarrhea with mucus. He is paraxial and disoriented with abdominal tenderness and distension. What will you do? So this is a quite sick, unwell patient, so I'm going to resuscitate him in the first go with high flow oxygen, IV fluids, and analgesia, and I will send all his bloods, including full blood count, UNEs, CRP, LFTs, albumin, culture, take an ABG. Then I would take, after some resuscitation, I would take the focus history with the diagnosis of ulcerative colitis, Crohn's disease, or family history of IBD. The patient was taking steroids. I would examine the patient, looking for peritonism and other systemic features of urinary bowel disease, perform a rectal exam and check for tachycardia, hypertension on the observation chart. I would insert a catheter NG tube, send stool for culture sensitivity and see diff. I would commence broad spectrum antibiotics, keeping in institutional guidelines. I would inform the SHDU, HDU teams and request a formal review of the patient. The abdominal X-ray shows a dilated transverse colon measuring 9 centimeters. His white cells are 18. What is the diagnosis? So it looks like he got acute colitis, and acute colitis is diagnosed using the True Love and Wits criteria, in which stool frequency more than 6, tachycardia, temperature, and hemoglobin less than 10, ESR more than 30. So as toxic has 5 words, so similarly 3 clinical criteria and 2 lab dependent. And toxic megacolon can be diagnosed if there is more than 6 times stools per day. No, it's a transverse colon more than 6 centimeters, and any 3 of fever, tachycardia, leukocytosis and anemia, any 1 of dehydration, altered mental status, and electrolyte abnormality or hypotension. So this will diagnose toxic megacolon. The microscopic hallmark is inflammation is extending beyond the mucosa. What are the causes of toxic megacolon? Ulcerative colitis, Crohn's disease, infective colitis, and pseudomembranous colitis. What is the prognosis of toxic megacolon? If it's good. If no perforation, mortality is 2 to 4%. If it's perforation, mortality 20%. So 5 times mortality is multiplied if it's perforate. And with UC, a proctocolectomy is curative. Optimum timing of intervention is crucial in managing this patient, and a multidisciplinary approach is imperative. Surgeons, gastroenterologists, and anesthetists. How would you manage the patient? So there are 3 goals here. Try to limit the dilatation, distension of the colon, correct fluid and electrolyte balance, and treat the toxemia and precipitating factors. So it should be joint care between gastroenterologists and surgeons. The initial system involves the aggressive fluid therapy, electrolyte imbalance, broad spectrum antibiotics, stopping all medications which affect the colonic motility, nil by mouth and parenteral nutrition, NG tube DVT. If the patient is not peritonitic or has been on steroids, I would ask for a CT scan to exclude a local or contained perforation. The patient needs daily abdominal examination, ideally by the same doctor, abdominal X-ray, blood test, FBC, unit, CRP. I would start IV steroids, and cyclosporin can be considered as a second-line therapy. When would you operate, and what would you do? I would operate if there was a free perforation, because it increased the 20% mortality, massive hemorrhage leading 6 to 8 blood transfusion, increasing toxicity and progression of the colonic dilatation. No improvement after 72 hours of maximal medical therapy. A stool frequency of more than 8 per day, CRP more than 45 after 72 hours. Need for surgery in 85% of the cases. This is called Travis criteria. So I remembered it as a Travis criteria. Steroids can mask the abdominal signs, so be vigilant. I would perform a subtotal colectomy. The patient is very ill, therefore I want to do quickest and safest procedure. Subtotal colectomy preserves the possibility for ileoanal anastomosis post-op. I would leave a long rectal stump with intact IMA for delayed reconstruction. I would leave a rectal catheter for 48 hours post-operatively to reduce the incidence of rectal stump blowout. I will start him enteral or parenteral nutrition, and I will liaise with my gastroenterologist colleagues in perioperative period. Thank you.